This is Dr. Charles Parker, and you're listening to CoreBrain Journal. It's a place where I connect both fresh discoveries and interesting different perspectives from advanced mind science with the realities of real people and everyday life down on Main Street.
Well, welcome, folks. Here we are one more time, Dr. Charles Parker, and we have a very interesting guest who's going to talk to us about addictions on many, many interesting levels. Dr. Tony Mele. He's out in Sovereign Health in California. And Tony, welcome. We're looking forward to talking to you.
Great. Thank you, Chuck. My pleasure. It's good to be here.
So what we're going to talk about, first of all, is who Tony is, and then we'll go from there. He's a licensed psychologist from Philadelphia, my old hometown, and brings 25 years of clinical and senior management experience on both the payer and provider sides of behavioral health. In his various roles, Dr. Mele oversees the integration of neurobiology and traditional psychotherapy to treat co-occurring addictive disorders. Of particular interest to Dr. Mele are creating interventions that are based on the cognitive substrates of DBT, which we're going to talk about that in a minute, and motivational interviewing, which we'll also be talking about. Very interesting topics. We haven't hit them in CoreBrain Journal, and Dr. Mele knows a lot about them. So with that brief introduction, Dr. Mele, tell us a little bit about what you do out there and give us a light window into your personal life, if you will.
Sure. Great. Thanks so much. It's really good to join you and your audience, Chuck. As you said, I'm a licensed psychologist. I'm actually new to Southern California. Was invited to join Sovereign about a year ago as Chief Clinical Officer. And in that role, I really play, I guess I wear two hats. One is I have the great fortune to make sure that all of the clinical programming that Sovereign presents to its patients is research-based, evidence-based. And we've done a lot of really exciting programming around addiction, recovery, sobriety, by superimposing some rather, I guess, stalwart theorists like Carl Rogers.
Carl Rogers, you broke up right there.
Yeah.
So say that again. You broke up right at Carl Rogers.
Carl Rogers. Okay. So we what we've done is we've taken such stalwart theorists as Carl Rogers, Maslow, Erickson, and superimposed their theoretical constructs on recovery. So it's been really exciting to be able to ensure that what we present to the community and to our patients is evidence-based and research-based. And in my second role is really as a spokesperson for the Sovereign way of treating addiction, which is based on our belief that the brain is a dynamic entity rather than stable and non-evolving. We believe that the brain's ability to heal itself is kind of the basis for recovery from addiction, maintenance of sobriety, as well as recovery from mental health conditions. So I have a really exciting role. I get to present that, in different media venues as well as in presentations around the country. But if I can share what I find most exciting, Chuck, is that it has really taken me 20 some years to get to this point. Mm-hmm. When I go back to my own history, my dissertation, we studied children who had been born exposed to cocaine during their gestation. And we looked at these children, they detoxed with a cocaine addiction. And this was during the late 80s and 90s when we had the crack epidemic sweeping a lot of the urban settings. And in my the piece of the research that I was fortunate enough to participate in, we studied these children when they hit Head Start classrooms. And what we were looking to see was, just as there had been a fetal alcohol syndrome, we were asking the question, would there also be a fetal cocaine syndrome, where children who had been exposed to cocaine would present with a fairly predictable set of cognitive, emotional, social, psychological sequelae. We were pleased to find out that those children who were removed from a drug-seeking environment went to Head Start classrooms, but were living with grandparents, other family members, even social services. Those kids were doing fairly well. They were maybe a little bit delayed, but basically indistinguishable from their non-exposed peers. However, those kids that remained in a drug-seeking environment, they were faring much more poorly. So we concluded that there probably wasn't a fetal cocaine syndrome in a classic sense of syndrome, but most importantly, we began to understand the role of the environment in helping to shape human behavior. Now, that was back in the 90s, so fast forward 23 years, we probably would see that as the role of the environment in what we would call pruning or shaping the neuron, experience at a neuronal level. So it was really exciting. It gave a lot of hope that these kids would not be stigmatized. They weren't sentenced to a life of cognitive impairment or social emotional maladjustment. It was very exciting, Chuck.
Well, it sounds interesting because it's really quite in line with what everybody's talking about nowadays in terms of epigenetics. And one of the works people that I follow a great deal is Dr. Bill Walsh outside of Chicago, who's talking about epigenetic change and neurotransmission. And he gets down on a molecular and cellular level. We've had several interviews with him here. And it's really right along the same path. And I think it's so very excellent that you're doing it with addictions, because addictions have been kind of Johnny-come-lately to the recovery process from a neurophysiologic point of view.
Absolutely. I think for us, as a mainstream recovery program and company, most of us are trained to treat addiction as a system disease. We've kind of gotten to that point. We're starting to understand it as a disease. I think that because many of us who are either non-physician clinicians, we often come from an attachment theory, a self-medicating theory of addiction. And I think that there's some room for that, because I think what neuroplasticity has to say to us is that the environment does play a role in how the brain processes stimuli. And we're seeing that. So what we do is we take a developmental approach. We do understand that the early childhood experiences are continuing to evolve and influence the brain. They did influence the brain. They continue to do so. And because not everybody with a challenging childhood history becomes an addict, there clearly are other factors at play. When they get to us, when a patient gets to us, what we try to do is look at how are they processing, a stimuli, a trigger. And this is radically different, because if you look at treatment, addiction treatment, what the mainstay has been: avoid people, places, and things. Mm-hmm. Yes. Avoid your triggers.
Yeah, avoid the triggers.
Well, how can
Absolutely.
you do? How can you do that?
How can you avoid them and understand them at the same time? Absolutely, excellent point.
That's going to make you. That's going to frustrate everybody. If you're an alcoholic in a urban setting, the chances are you're going to be running across a bar rather frequently. Okay, so we got to get away from this whole avoidance thing, and instead what we need to do at a neuronal level is help folks process the trigger differently, train the brain to process differently, so that if two people, an alcoholic and a non-alcoholic, are presented with a can of beer, the excitatory neurons in both, function similarly. That's the goal. That the alcoholic doesn't have, this response, this synaptical response that propels, an impulse control problem. Okay.
Mm-hmm.
So we're really trying to do two things in our treatment. And this is very, very new, very, very new. We're trying to look at what are the cognitive processes that underlie an addiction. Okay. It's difficulty shifting attention. All right. That's the obsession. And it's difficulty delaying an impulse. That's the compulsion. So we're trying to look at, this in somewhat classic terms, obsessive compulsive, but how do we get to the cognitive functioning, the brain functioning that underlies that? So that's kind of where we're at right now.
Very interesting. Now, so then what is your program like? If that sounds, I'm sure some of our listeners are thinking, oh my gosh, it's way over my head. How could I possibly get involved with something like that? So if you could give us a couple of pictures, a little bit of an idea of how a human being coming into a facility would be evaluated and treated in regards to what you were just saying.
Sure. Well, there's a couple of different strategies that we use. One is certainly there's a whole education that has to occur. Okay, and so we go into, when we say that addiction is a disease, well, what are we really saying? Because that's kind of like a buzz phrase now.
Yes,
everybody knows that they're supposed to say that, so they all say it.
Yeah.
But when we start to explain, what is neuroanatomy at a very, at an understandable level to the patients. Okay, this is what your brain is doing. This is how, you are responding to a trigger. We are in the process of modifying how we use neurofeedback to help, give a picture, of that, of the brain response. Then there are two other things that
stop right there. Let me interrupt you because that's you tweaked my interest. So in that, before we move on to the next one, it's neurofeedback is a serious interest that we have. And does that mean that you do a QEEG on the front end to really understand the foundation, the brain foundation?
Right, and think of neurofeedback in two ways. Exactly what you just said, that gives us the baseline. And then think of it as an ongoing measurement-based tool. Okay, so it's giving you feedback as to the efficacy, as to the results, how well your treatment is doing, as well as helping to be the intervention itself.
Yes.
So it's kind of serving two functions. In addition to that, we have Sovereign through our leadership team has developed what we call neurobics, kind of like aerobics, but we call them neurobics, and it's a proprietary set of games that we are testing, applications, computer applications that are designed to. It's really, really cool. They're designed to address the cognitive deficits that appear from a standardized psychological battery. So this is really neat. What it at Sovereign are dedicated to a cognitive and emotional evaluation. It's probably more robust than most folks are even, have the capacity to do, because we have a whole cadre of licensed psychologists and psychiatrists who are administering these and interpreting these tests. So let's say you and I both take an MMPI and, a personality test like the MMPI, and perhaps a Connors for, attention deficit. And we start to look at what does Chuck's profile look like? What does Tony's profile look like? And that allows us to individualize the treatment. So let's say you score high on an impulse control problem, I score high on a depression. Then what we do is we can take those two data points, your impulse control, my depression, and we can take these neurobic games to try to change the brain's perception, perceiving a stimuli, interpreting a stimuli, and acting on a stimuli that's either depressive or impulse control related. It's really starting to tie in the cognitive and emotional presentation to the addiction at a very basic level.
So it's self-management on a neurologic level.
It really is. It's self-awareness on a neurologic level. Absolutely. Absolutely. And I will tell you the other thing that we're starting to do, and I haven't finished this, but this is where I think I want to go next, is I've been working with our CEO on this, and we have a chief scientific officer. Dr. Sharma is our CEO, and Dr. Kumari is our chief scientific officer. And what we're starting to look at is what are the cognitive substrates that are required for DBT and motivational interviewing? Because if when I go around and I ask people, are you using motivational interviewing as a technique? Are you using DBT? Of course, everybody raises their hand because it's the latest fad to hit, our industry. And there's a lot of efficacy, but the problem is it's all cognitive based. And if you have a person who's been drug seeking or drug using or alcohol using for 10, 12, 15, 20 years, their cognitive functioning clearly has been impacted. Yet you're going at them with a treatment that's all cognitive. So we have folks whose subcortical functioning is impaired. Yet we're going to give them we're going to use a tool such as motivational interviewing, which requires them to do sequential organization, planning, consequential thinking, many of which are tasks that their alcoholism or their drug addiction has impaired. So we're trying to get to how do we kind of retool DBT and MI, which we know intuitively are valuable to meet the specific cognitive capacity of the patient in front of us.
Well, that's great. Let me interrupt you again, because now I'm listening with our listeners here, and I'm thinking about some deficits that they're going to have in terms of the communication with us. Now, one of the things, folks out there, cognitive has to do with thinking. It's a buzzword we use all the time. Tony and I are happy to use it. We use cognitive and without thinking, but thinking is what cognition is about, as opposed to feeling and behavior. Feeling and behavior are two other brain activities, but cognition, and when he was talking about subcortical and cortical generally speaking has to do more with the cognitive side, and subcortical has to do more with affect, emotion, and what's going on with feelings. How you affect an emotion may not, be out of whack on some level where a person's stuck with trauma or something. And then, so there's what Tony's really talking about is connecting these two in some operational terms so that it would really help a person with self-management. Now, Tony, you also talked about something else there. Please share what these terms are, because I know a lot of our audience don't have any idea when you're talking about DBT, dialectical behavioral therapy. And let's take a moment on that, and then on motivational interviewing, MI, please.
Sure. Thank you. I appreciate the clarification. DBT, dialectical behavioral therapy, is a technique developed by Marshall Linehan to help folks who have a hard time keeping their emotions under control. These are individuals who go from 0 to 60 on the emotional speedometer very, very quickly. They get easily aroused, easily upset, and their level of upset often can look more extreme than the situation might warrant. So what this technique does, it's called dialectical because it means there are two poles. That's dialectical, two poles. Mm-hmm. The one pole is the therapist accepting the reality of the patient, and the other pole is to get the patient to acknowledge a need for change. Okay? Mm-hmm. So it's accept, but it's not approving. It's accepting and helping. Okay, so obviously,
just a second, stop right there. You cut out, and it was an important phrase. Accept and helping, and you broke out right there. Helping.
Okay, and helping helping the patient acknowledge the need for a change.
Okay.
Okay, helping the patient see that yes, their emotional state is valid. Okay, we don't judge it, we don't condemn it, but we also try to help them see how is that emotional reaction helping you.
And what can you do about it?
On to the same stimulation that got them upset. Okay, and there are a series of techniques that the dialectical behavioral therapy will use, and one of the very first ones is, and I'm sure this is probably another buzzword out there, is this technique called mindfulness. Mindfulness, and what mindfulness is, it's sometimes people think it's meditation, and it's not meditation. Mindfulness is the ability to stay in the present moment with the very emotion that you otherwise might try to run away from. Okay? And so oftentimes we try to help individuals in the therapy simply sit with the feeling of frustration, if that's what they're feeling, or anger, or resentment, okay, rather than allow the patient to act out and escalate emotionally and get upset. We try to help them tolerate that. That's a big part of DBT, okay? And so, again, the ability, think about that, the ability to stay with a distressful or upsetting emotion. How much cognition goes into that, okay? The ability to tolerate frustration. Well, it's certainly, the frustration is an emotional response. The cognition of being able to stay put, not wander, not move, hold your impulse, okay, not act out. Those are all cognitive skills. So it really is bridging. I think you said this a couple minutes ago, Chuck. It is really connecting the emotional and the behavioral. And it's a wonderful technique. However, not everybody with a 20-year history of alcoholism, their cognition is not always going to be intact enough to be able to tolerate that. So we have to do this in very small pieces. And one of the things that we do in the therapy, and I don't know where the research is on this, but I suspect there's a wealth of opportunity here. The transaction between the patient and the therapist, okay, the dialogue. I suspect because dialogue and communication is cognitive as well as emotional, that is an important part of how we can help remediate the addiction in talk therapy. And I think we haven't really tapped into how we can do that. And I think that's where motivational interviewing comes in. Motivational interviewing acknowledges that communication between the therapist and the patient is having a neural effect that is changing the brain based on the communication pattern. All right, so that's and motivational interviewing is another series of activities that's designed to have the patient develop some level of insight into how they would benefit from changing their behavior. So think about that. One of the big techniques in motivational interviewing is help.
You cut out right there on the word helping.
One of the primary goals or techniques of motivational interviewing is to help a patient envision how their life could be different. Mm-hmm. Mm-hmm. So think about the cognitive requirements. You and I might sit back, and many in our audience might sit back and fantasize about how life could be different, mm-hmm. and maybe even take steps. I can do this, and then I can do that, and then I can do that, and start doing some sequential planning and do the pros and cons of each of those steps. Well, that requires a certain level of cognitive functioning. And what we're looking at doing at Sovereign is saying, what are the steps, the cognitive requirements, each step along the way? what is underpinning motivational interviewing from a cognitive thinking analysis. And I think if we can really get to that, we're going to make a great contribution to recovery. Absolutely.
Well, it's an interesting thing. As you're talking, I'm imagining the many years of my own work in recovery activities, and ran a hospital unit for a long period of time, and wrote that book, Deep Recovery, back in '92. But my experience there is it was always so negative with the people, and in terms of looking, in contrast to what you're saying, into the past and what was wrong here and what was wrong there. But it's what you're talking about is a creative, imaginative, forward-thinking, where will we go and how are we going to get there kind of approach, as opposed to, you really screwed up here and you screwed up there. Now what are you going to do about it? And it gives a person,
it's that.
Go ahead, please.
It's that. What is that? There's a manuscript out there. It may actually be a book. You're not stuck with the brain you were born with.
Mm-hmm.
And it's the same idea. We all have past histories, and one of the I think one of the contributions that's being made. I think there's some issues, but I think a lot of Dr. Mate's work is acknowledging that our past, we can't deny it. Our past has contributed to who we are today, positively and negatively. All right, so how do we understand its role? And for us, not at a purely psychodynamic perspective, but how do we understand its role in our brain development? And how do we work with that?
Yes.
We're not a slave to it,
yes,
but we can't ignore that it's there.
And how can we use it to look forward? Yeah. The issue
Absolutely.
is, I think this is what you're saying that's so, in fact, in itself, imaginative and interesting, because you're saying, okay, the past is the past, but I'm going to break it down almost too simplistically, but how can we learn from it, and what can we use in that learning process to do what we're going to do next?
Absolutely. We have to, embrace it as a tool to move forward. Otherwise we really run the risk of being very disconnected. And I would think that for addicts to be disconnected is probably not, for any of us really, to be disconnected is not a good thing. So,
well, Tony, our time is winding down here. I want to ask you another couple quick questions and help.
Sure.
We could talk for an hour here very easily, and I'm sorry to cut you off because this is such an interesting conversation. But tell us a little more for the listeners who are saying, hey, these folks are on the right track. Number one, how do I get a hold of them? But I should say that. Number two, how do I get a hold of them? Number one is, what does a treatment program usually consist of? Is it a certain period of time? Is it the old 30-day? Is it 6 months? What do you actually do with the treatment program? And then how can we get a hold of you?
Sure. Well, I definitely appreciate that. The way treatment is highly individualized. And so based on the evaluation that we conduct, and based on the patient's presentation, that will drive the length of stay. If they enter at a detox level and they have a fairly benign detox, rather standard detox, and move into the different levels of care, it can be a 45 to 60 day process.
Mm-hmm.
We do have a robust e-therapy program. So the folks who want to maintain contact with us upon discharge, and they move far away, we can hook them up to a Skype therapy, secure Skype therapy. Chuck, we are in 9 locations across the U.S. with plans to open up 4 more actually within the next 6 weeks. We're in different licensure stages, in a fairly a large presence across the U.S. And again, depending upon what the patient's needs are, that will really dictate the length of stay.
Well, that's so interesting. Now, give us a link so we can pop in there. I'll have it included in the show notes, but if you could say it out for those who happen to be driving to work, that'd be great.
Sure. I can give you the 24/7 admissions number is 866-594-3271.
Okay.
So that's 866-594-3271. And our website is www.sovcal.com.
Okay, I'm glad we clarified that, because I would have been dialing up Sovereign. That's great. Tony, this has been too short a conversation. We've got to talk some more. This has been very, very interesting. I appreciate you coming on board with this, and it's really an innovative, different way of thinking about how to move forward. I mean, it's really, as you said in the beginning, I don't know whether we said it on recording or whether we were talking about beforehand, but it's an appreciation of neuroplasticity applied in a clinical way. I mean, you're actually saying, how do we grow these brain cells? How do we respect them? How do we take the pain that we've been in, somehow understand it, appreciate it, and manage it, but move forward from there? And it's very innovative. It's much different than the old cathartic theory of mental health, where you kind of run around and scream for a while and get it out of your system.
It's much different from that, and I think there's a lot of hope out there as a result. So we're really excited to be at the transformative and at the vanguard of this whole process and this whole approach. So thank you, Chuck. Thank you so much for the opportunity to share with you.
Thank you, Tony Mele. It's really been great listening to you. Really appreciate your presentation and our opportunity to talk together. We'll do this again sometime. Appreciate it.
Sounds great. Thanks so much.
Thanks for listening to CoreBrain Journal. We're working every day behind the scenes to bring you reports that connect research benches with those street trenches. Here we share the complexity of mind science because, as you know, details really do matter. One of the most pervasive, misunderstood challenges is how commonplace medications, like those written for ADHD, are used so regularly without clear guidelines. If you think you'd like more specifics, take a minute to download my 2-page PDF packed with video links and references on the absolute essentials of how to start ADHD medications. They're easily available at CoreBrainJournal.com/start. Thanks for listening. Do connect and stay tuned. Together we can make a difference.